had low expectations and was planning on using it more as a training run. And then I ended up just feeling really good, and I was going faster than the pace that I'd been planning on running, but my heart rate was low and it felt very comfortable, and I just was kind of looking around enjoying the day, so I just stuck with that and then planned on picking it up towards 7 kilometers to go, which I did. And you wouldn't believe it, I ended up running my fastest 10K in the back end, but also ended up running the exact same time as my previous half marathon.
PB.
To the second.
Yeah, to the second, crazy.
36 and 28 seconds.
Did you look at the millisecond?
No.
No, it was just to the second.
Just to the second. The exact same time.
Yeah.
That's just, how? How is that? Ugh, can't believe that.
Yeah, odds of that.
And the annoying thing is that I had it in me to go faster at the start, so I definitely had it in me to get a PB, but anyways.
And you think it's because you've been doing plyometrics, not the year of training extra? Because it was a year, was it the Sydney
September
one?
September last year.
Yes, what's that, 7 months? Because you've been adding in, what's been the plyometrics you've been adding in each week, and frequency and type and progression?
So I've been doing plyometrics 2 times a week.
Yeah.
And on one day I'll start off with some skipping, and then we'll go into like single leg skips on each side. So I'll do like 4 sets of 10 single leg skips. I might be doing some depth drops. I'll do some band assisted pogo jumps, which are good because I feel like they help to get some really good height, and some double unders as well have been the other plyometrics that I've been doing, because then they just make you jump higher rather than skipping. It's kind of easy. Double unders, you actually really have to get off the ground. So they've probably been the main ones that I've been focusing on, and I'm going to keep doing it, definitely. I think it's been helpful. Yeah,
twice a week at the end of your leg session?
At the start. So previously I would do more like power-based plyometrics. I would be doing like box jumps and broad jumps, and more focusing on like the biggest effort. Yeah. And so I've changed that to more like repetitive, lower intensity, I guess. And I think that just correlates better with running. I reckon it's making a difference.
Lower intensity plyometrics.
Well, like instead of doing like 4 big box jumps,
but you're still doing each
20
jump.
20 double unders.
Yeah, but you're still doing each jump with intent.
Yeah.
Like each rep. Because I know there's the hypertrophy, you've got to have enough of a stimulus, you've got to be over 30% of your 1 RM. Is there anything similar with plyo, where you've got to do it at a certain degree of intensity to get the benefit?
I don't know.
You don't think?
I'm not sure.
Yeah. Do you recommend people do it, like say for Achilles, any lower limb tendinopathy?
I guess you make it harder by making it on one leg, or as I said, instead of just skipping, doing double unders, so you've got to jump higher. Yeah. Yeah. Yeah.
I just remember reading somewhere that it had to be that you've got to do it with intensity, and a common mistake people do is not, and for like training stiffness, is not doing it hard enough. Like you just kind of jump and land, but you should be trying to do it pretty hard and with a pretty high level of intent.
I would say it is. Yeah, like 10 single leg skips is pretty tough for me at this point in time. Like before that, after having an Achilles tendinopathy sort of earlier this year, hopping on one leg was challenging. So being able to do that and alternate between sides for 4 sets that's tough. Yeah. And that's been getting easier though. And so now, I think it's helping with running. Yeah, good. Yeah.
What did you think of this week's episode with Antony Lo?
Yeah, great. I'm really excited to listen back on it. It was good. I got a lot of good principles that I think is applicable to everything that we do every day. I think everyone will get something out of it. Yeah. And it's less about specific formulas and more about different ways to think and approach pain and patients.
Yeah, he reminded me a little bit of Greg Lehman with
He reminded me of Dave Renfrew.
Oh, really?
Yeah.
Well, I guess they're kind of similar.
They're all kind of the same.
Just those kind of complex topics. Yeah. That are always going to be complex, but he had a pretty simple approach. Yeah. A bit like the mantra of calm shit down, build shit back up. It was a bit like that. It was good. And he's funny, which makes it so much better. It's just like funny to listen to, and he's good to joke around with. It was interesting. I didn't even realise he was so close. He's in Sydney. Yeah. Yeah, for some reason I thought he was overseas. I think I asked him in the start, like, whereabouts are you? And he's like, in Sydney.
Yeah.
Yeah.
I did know that.
Yeah, had no idea about that. And a different, interesting perspective, and certainly knows someone that's across the research, similar to Greg, someone that's certainly across the research can quote the statistics and the level of, activity in EMG studies, but able to just simplify it and say, we've got this, we've also got this. This is pretty simply how we should do it and how we can do it.
Yeah, and similar to what we spoke about a few podcast episodes ago, you've got to know the foundation of that. So you've got to know the research to be able to simplify it that well and be able to apply it safely to people.
Yeah,
and he definitely does.
How about his clinic is in his house?
Yeah.
What do you think? I don't know if I could. I mean, each to their own. I just don't know if I could. And he's got a tennis court in his house. That was funny. And then in the video, you could see he's got all the weights behind there. I don't know if I could have a clinic at my house. What do you think? Out the back, would you do that? It'd be an easy commute to work.
You would have patients over on every hour of the waking day if that was the case.
7 a.m. to 9 p.m.
You would.
You can come home for dinner if you have a cancellation.
You would never get out of the work shed if that was the case.
It wouldn't be good. At all. I got a case to run by you this week. You to tell me what you would do. So I saw someone.
Should we say this for the Patreon?
No. We've got plenty of Patreons coming out. This is a good one. Plenty of cases to talk about on that one. If you are listening to this, by the way, that's a good way to bring it up. Our Patreon link is in the bio. Good news, everyone that signed up has not cancelled, so they're obviously enjoying it, which is good. So if you want to head over there, I think it's fortnightly, but we've also added in every month we're going to, I say where, but I think I'm going to, with Kelly jumping on as well, doing a monthly case study live. So we'll all just jump on via Zoom and talk for kind of 30 to 45 minutes through a case as an example and kind of have a bit of a background and some real pictures and examples. So I think that should be good, where you can ask questions. We can all kind of ask questions and discuss what we could have done better, maybe could have worked on, that kind of thing. Which will be good. So someone that I saw last year with a bilateral tib post tendinopathy, insertional, pretty plain, flexible foot, high level soccer player, and that'll manage all fine. Recently in the last week had sent me an email about getting some shin pain, and they had moved down to away from where I am and asked if we could jump on telehealth to ask a couple of questions about getting some shin pain. So jumped on telehealth, and it sounded pretty vague, and I thought it was just going to be MTSS, maybe a more sinister version, but they'd said in the email they're getting a fair amount of pain. Jumped on telehealth, which was interesting because I haven't done much telehealth compared to what physios have done, and it was really enjoyable. But reported bilateral pain through the medial border. It started about a couple of months ago, and then in the last month has got progressively worse, playing soccer, training 2 to 3 times a week and playing on the weekend. Able to, in the last couple of weeks, only able to get through training with taking Voltaren, or taking anti-inflammatory, still painful. In the last week and a half, had started to get pain at night, and in the last...
On both sides?
On both sides, but worse on the right. And then in the last 4 days was keeping this person up at night. And on the telehealth, I just said, can you kind of feel down your tibia? Because it's a pretty easy spot that people can feel down there. And they had pointed, there was one location a little bit, imagine about halfway down the leg, a little bit higher than halfway. Like, yeah, it's really sore there. And it's more sore than anywhere else kind of along the tibia, but everywhere else was a little bit sore as well. And then as soon as we did one single leg hop, pain, and able to point exactly to where it is. So based off the telehealth, what do you think? What would you be considering? Like, what advice would you give on the telehealth?
You need to get an MRI and stop running until we rule out a stress fracture.
Yeah.
That's sounding very stress fracture to me.
Yeah. Is there anything you think that I could have done more via, and I may have forgotten to mention it, but I'll let you know, anything more I could have done via telehealth to confirm?
What was I guess you could have asked what their training load was like, and then you could probably ask if they've had any changes to their diet, what their energy levels have been like, if you wanted to go into some of those other factors that might be
I could have done that.
Influencing their symptoms more.
Anything else, I guess you could say clinically, do you think?
I don't think you need to.
Yeah.
If they've got localized pain
enough of
on
that,
palpation,
yeah.
and
night
they've
pain.
got pain on a jump or a hop, you're not going to do anything else until you've ruled out a stress fracture anyway. So further assessing isn't going to sway what you do, I wouldn't say.
Yeah, and there's certainly enough clinical justification to warrant sending for an MRI. And I thought to myself,
did you just MRI the one side or both?
Well, this adds a layer of complexity because they just had seen me previously and just asked to email. They where they live, they have another health professional that manages the team. And I was like, great, just go and... They had training that night. I said, great, just go and speak to them and just see what their kind of opinion is. Because, it's pretty straightforward. If someone has... I'm thinking to myself, if someone has localized tenderness, progressively getting worse, it's in that area, and we're getting pain at night, taking Voltaren to get through there, like, you need to confirm that to make sure. So... yeah, I'll send them an email to see where that's gone. But it was interesting by the telehealth. It made me want to do that more, but then I thought to myself, with that kind of condition, and I imagine anything proximal, certainly you could, but when it comes to the foot and the ankle, not to say inner soles and shoes are everything, but they play such a... And I've said this multiple times.
Can't you still recommend shoes over...
Well, shoes definitely, but you can't assess shoes, and it's hard to assess someone in their shoes. And inner soles and orthotics play a huge role in the foot and the ankle. Like, I use them quite a lot because of, they're moving tissue around.
Yeah, it's funny you say that.
And I wouldn't be able to modify them. I wouldn't be able to change them. And, we don't... Like, don't prescribe any custom orthotics really at all. It's just modifications on other ones. And then, short term, long term, you come out of them and you're back to normal, a bit like a shoulder sling. But the ability to adjust them and modify them is one of the things that you just can't do when you're 5 hours away.
It's funny you say that because I have a patient that I see who's actually situated in London that I see via telehealth for some running programming after a foot injury.
Yeah.
And
is it an Achilles or is it foot?
I think it's their tib post or their plantar fascia.
Yeah. It's a bit different.
Well,
in that area, down around there.
They were on the mend and they're doing heavy loaded calf raises.
Yeah, it doesn't really matter, does
they're
it?
running. The main thing that they wanted to see me for was to gradually build up their running anyways. So
are you still seeing that person?
Yeah.
Oh, cool.
Yeah. But I actually referred them to Ian Griffiths the other day for that reason, because I thought that they've got quite a mobile, flexible, flat I think it's an asymmetrical foot type that might benefit from...
Oh, when it's those medial structures, if someone comes in with a tib post, it's this inherent gut feeling that you get that you're like, oh, you're going to really do well. They don't always, but majority of the time they do.
I think they'll maybe...
You whack a load on.
At least just an assessment, like it's hard to assess via telehealth if that's the case. So I was like, just go see Ian, he's great.
Yeah, it got me thinking of the ways that you could test... Because you want to know, like, what ways and what things can you test if they're going to be effective. You could almost get someone to low dye, and we've got a video on our PhysioTrack exercise that's how to low dye yourself, and you could almost get them to do that and be like, is that effective? Great. Go to the chemist or go and see another pod where you live and just get a pair of off-the-shelf inner soles. Yeah. But interesting. Just wanted to check with that one. The other one was... I had a third shaft metatarsal stress.
What we talked about last week.
Stress reaction, but I want to talk to you about the management. Stress reaction, pretty run of the mill, like nothing too severe, probably like in the middle as you would expect. And the management I was thinking based off when we went to Dr. Willie's course was a 6-week time frame of in a short cam walker at week 4 coming out and starting some foot intrinsics, which I probably haven't gone as hard as what he was saying on the foot intrinsics. I've always given them like some stuff out of the boot, some inversion, eversion, but probably not a really extensive foot intrinsic program. And this person's a pretty high level dancer, so it's really important for them. But the other thing that I did, again, went pretty hard on was the contralateral leg cross training. And I was thinking to myself, like we did some wall sits, both legs wall sits, we did some hopping, some jumping on the other side, we did some single leg squats, we did lots on that side.
Yeah.
Do you think there's any risk on that? If they're only doing it once a day and they've done it before or even every second day, like, is there any risk there? Am I missing something?
I think the only risk would be if you're getting them to do more hopping and jumping than they had previously been doing, and they are have like osteopenia or something like that. Yeah. That would be the risk. That would be the only risk that I could see.
Yeah.
If they're still being deloaded from what their normal is, then I think that's a great idea.
Yeah.
Something that they need to do, especially because even though you've had a bone stress injury on one side, the risk is still increased for it to develop on the other. So some sort of strength training and capacity building on the other side to try and minimise the chances of that is important. Or any injury really, because it's a 6-week period of them not at the same sort of training load as they were at before.
What would you do, and this person's younger, for someone where you want to, like, I did some wall sits, what else did we do? Some wall sits, some lunges, and a kind of like a single leg squat hold. No, actually it was just wall sits and just lunges on the injured side. Is there anything else that you would do more proximally for someone that doesn't have access to a gym but has plenty of time to do bodyweight style?
Yeah, you could do more hip stuff, so they're both a bit more quad dominant. So you could do some like
we did some arabesque.
Yeah, sure.
Yeah.
Like a single leg deadlift.
You could do
like a hip thrust or a bridge or like a foot elevated single leg bridge or double. Yeah. You could do that on both sides.
Yeah.
More hamstring dominant.
Yeah.
You could do some Nordics. You could do leg extensions.
How would you go with Nordics? Is that putting too much stress through the metatarsal with your feet pointing down?
Depends on how you set it up, I suppose.
Yeah, I guess if you set it up with your heels.
Yeah, if you set it up with something over the top of your heels, then no. But if you're like digging your toes down into the ground that's probably not the best idea.
Yeah. Yeah, it just made me think of how important...
Or you could do some like clams.
Clams would be good. Just anything, I guess. It just makes it how important, although it is foot and ankle localized, it's so important to keep that just overall conditioning. And I know it would be impossible to research to see how much better somebody does with versus without that, and have them two groups plus a control group. Like you're surely getting back to... I mean, you have to be getting back quicker, I would assume.
In terms of return
to sport, and also, I want to say an insurance against reducing your risk of the future injury. Yeah. But you think of someone that spends
like... too many things into bone stress injuries to be able to control for that.
Managing surfers and dancers with foot and ankle pain it's difficult. It really is, because, with running, it's pretty monotonous. You run in a straight line, you can control volume and distance, and you can control so many things, offload it with footwear and intersoles. But with those kind of cases with surfers and dancers, it's really, really hard. Like surfers and sesamoids, it's just so hard. Even footballers as well. I had
a lot more unpredictable.
A high-level soccer player, and playing around with the forefoot offloading in a football boot is so difficult because one, it's hard leather. You run out of real estate in there, and touch and comfort is so important. So you do all this offloading and twink it, and you kind of think you're like, yep, it's right. But you think, how much am I really involved? Like, is it an extra 10 or 15%? But I guess if it's enough. For the forefoot specifically, the arch and the heel is not too bad. Now, which is good. Good. Well, we'll leave them there. Leave it at and leave the listeners to listen to
This is part 1?
Yeah, this is part 1.
Antony Lo?
Yeah.
Physiotherapist?
Yes.
From Sydney.
Enjoy, guys.
Thank you so much, Antony, for joining us on the podcast today. We're very grateful for the time and being able to pick your brain over the next hour. So can you tell us a little bit about yourself and how you've gotten yourself to where you are today?
Oh, my goodness. I'll give you the pre-prepared answer. The one that I've written down many times. I'm a physiotherapist, a musculoskeletal physiotherapist who works at the junction of musculoskeletal, sports and pelvic health. And I help health and fitness professionals, as well as clients who struggle to achieve their goals by cutting through the BS and thinking outside the box. So yeah, that's that's my positioning statement. But ultimately, I'm a physio. I've worked in the public system initially for 3 years, and then I bought one private practice, and doubled the business, and then bought another one a year later, and ultimately quadrupled that business. And then I sold the first one about 8 years after I bought it, and the second one I sold 11 years after I bought it. 12 years really after I bought it. So I've been educating for over 10 years, just seminars for the public as well as for health and fitness professionals. I've had the privilege of traveling overseas, and because people want to know how to do the stuff that I do, and I like joining the dots in seemingly disparate areas and coalescing it all and really focusing on, well, what's the bottom line? It's good to know all this stuff, but how does it interact with me and the client? And I like to think that I've spent a lot of time working on the educator side of things, not just teaching the way that I've been taught on other continuing education courses.
Yeah, interesting. This could turn into a business podcast. You did pretty well to do that business-wise. That's awesome.
Oh, thanks. It's just lots of hard work and lots of support from my wife, primarily behind the scenes, and all the teaching assistants that I have around the world. And it's that ability to bring people in that know more than you, and then also the willingness to know that you just don't know very much ultimately, and always wanting to learn and improve.
And whereabouts are you right now? As in, don't give your exact location, like town, city, country.
I'm in my clinic, which is at the back of my home in Kogarah Bay at the moment. I work from a clinic part-time, like just two evenings a week in Oatley. So I'm in Australia at the moment, but I've been all around the world this year already so far.
Yeah, awesome.
Cool. You mentioned as well that one of your favorite things to do is sift through some of the BS that's out there. And I think that's probably one of the main things that attracted me to your page and your platforms. What's some of the main things that come to mind when you say that?
We don't have long enough in an hour, Kelly. Seriously. Look, a common one is, for example, core stability. So we teach people all sorts of stuff about core stability, and we think that an 80 millisecond to 120 millisecond delay in activation of your transversus is rectified because you're teaching them to isolate transversus. Like, we know since 2008 that that's probably not true, and yet this is what we still tell people. Another myth is that, when you put your fingers just medial to the ASAS, when you feel transversus activate, you'll feel it like go anteriorly, rise towards the ceiling when they're on their back. That's garbage. Like, it just doesn't do that. Another one is that the neutral position is the best position to train in because of blah, blah, blah. It's actually the hardest position to train in. The very definition of the neutral zone is where you have the least amount of passive elements providing resistance to translational movement. And so it's got the least amount of stability. It's the most unstable position of the joint. And you rely on active elements, therefore, to support the joint. So the reason why it probably helps is more likely that we're teaching people how to support it in the hardest possible position. And the reason why people like to extend or flex is because they're looking for contributions from passive elements. But people think that doesn't count. And, other ones like gymnastics technique, for example, is the best technique to teach people how to do things. So that's garbage. Yeah. That's, it's the hardest technique. When you're looking for the best of the best, only the best can do the hardest way possible. So gymnastics technique is the hardest technique possible. When we look at pelvic floor, we can, I can go on and on. That's just off the top of my head, which I've been agitated about recently.
And a lot of those are the sort of questions that I want to start to explore a little bit further as well. So you mentioned a lot of the stability, core stability things, and that's something that I would hear
regularly on the daily, I would say, with patients coming in. And it's so hard because it's advice that has been told to people through many, many, many different health professionals, doctors. They've read it, they've breathed it for forever. And it's very much wrapped around, it's a very strong belief that they hold. And I find sometimes it's often very hard to break that down. And more often than not, I'm sort of using them as evidence and their symptoms as evidence that maybe it doesn't always have to be in the neutral position for them to feel better. But I'd love to get your thoughts on, how you sort of approach that when someone is coming into the clinic and explaining the need for their core to be for better core stability for their back pain, for example.
Can I add to that? Sorry, and where does that kind of come? Where has that come from? Where has that kind of narrative and idea? Is that something from the 80s and it's just progressed as well?
I got no idea, man. Seriously, the whole the problem. Ultimately, the problem is that personal experience is the most powerful agent for change, and personal experience is the lowest form of evidence. So, we've got this competing interest, really, because if we want people to change, like Kelly, you were saying, giving them an experience that this doesn't have to be true is great, but it's actually really low-level evidence. But it's most likely to create change. So I don't know where it comes from. I think it's just well-meaning people who don't understand what post hoc fallacy is. So, the results don't prove your reasoning. I can tell a story. So a common story that I tell people is that there's a stone. I don't have my special stone with me right now, but this special stone has got magical properties. And I noticed when I was watching a physio work and, I was asked to mentor them, when I stood with that stone inside my right pocket, when I stood close to the client and they were close to the stone, they started getting better. And when I stood on the other side so that they were on my left side away from the stone, they didn't do as good. So I gave them the stone to hold and they just started getting better. Now, you would likely think, my God, that's a lot of BS right there. and yet, choose your favorite thing that you think works. And I could tell you the same story. So I taught the person, or the other person taught the client how to isolate their transversus. And once they started being able to isolate their transversus, they were able to make a change and they started improving in their pain that they'd had for the last 10 years. And if you like that story, you go, yeah, right on. And if you don't like that story, you're going, nah. But it's the same level of evidence as me with a stone in my pocket helping somebody, because at the end of the day, the results happened, but the results don't prove the reasons why you think it happens. And people just don't understand that. It's so counterintuitive to think that. I have to remind myself, it requires mental effort to stop yourself from telling yourself a story. So I just tell people, just observe the story that you have for it and just add another one. Add at least another story to explain why it might have worked. And then you're closer to being more scientific in your approach.
Do you think that the people need a higher level of critical thinking to just think that? To be like, I've done something, but that doesn't automatically mean what I did work? Is that, that seems to be pretty simple. And I've heard people like yourself explain that. It sounds pretty straightforward, but people just seems to not see that happen.
It's not normal for people to do it. You don't get taught it. You have to practice it. It requires mental effort.
Yeah.
I'm sure that they teach it at uni at some point, but people just don't pay attention. And then you go out into the workforce, and at the end of the day, you tend to do what your boss says, and you tend to believe what they say, because otherwise you're likely to be out of a job. And then, so there's a power dynamic there that's unfair. There's a whole bunch of reasons why I think there's problems with thinking that way. So I've been working on trying to help health and fitness professionals to be able to work the way that people want without having to believe the reasons why. So, you know, coming back to the core stability and the change, and how do I manage, you know, people who really strongly believe they have to. There's no evidence that doing that is going to be useless. In fact, there's evidence that it helps, and there's just as much evidence that that's helpful for some people as doing other things, and all things seem to be better than doing nothing. Maybe combinations seem to be better, but ultimately, when you look at the effect sizes, on average, they're not usually that good. But when you look at the range of people who had differences, like there are people that significantly got better that way. But on average, when we apply it, we can't say that that way is better than other ways in general. So if they really believe that, cool. Like, I'm happy to work with them on that and open the door that maybe there are other reasons why it's working. And the other thing to do is just design a movement experiment that breaks their beliefs. Because experiential learning is the easiest way to change what people believe. Yeah. Confusion is the goal. Yeah. Once you can confuse somebody, you can start learning.
Yeah, that's awesome. I love that you said that. That's cool. And then pelvic floor strengthening and core stability training often get sort of lumped into the same category. Do you see that there are big differences, and when are they indicated or not indicated? And
yeah. So look, pelvic floor muscle strengthening is useful. There are situations where it's not shown to be that different for the measured outcome. So, for example, before and after surgery for the, say, pelvic organ prolapse. But the benefit of actually doing something consistently, there are other benefits as well. There's psychosocial benefits if you do it in a group. There are economic benefits if you get a fitness professional to teach it instead of a physio, because it's just going to be cheaper, so more accessible. I think we are far too ready to hog the work instead of farming it out to much more efficient ways and being more like consultants. You know, there's plenty of work for everybody, and around the world, maybe not Australia as much, but around the world, there's so many more people that need pelvic health physio than there are pelvic health physios. Like, for example, in Hungary, I think there's like 2 for the whole country.
2?
Like two. That's what I got told by somebody recently who's from Hungary. Yeah, do you know what I mean? Like, can you imagine trying to be that pelvic health physio, trying to run the classes, trying to do don't teach fitness professionals how to do it.
Rebook someone to see you in 3 years.
Do you know what I mean? Yeah. So, I think it's much more important to be able to work with that. I think it's important to do those things. I think that pelvic floor exercises are important to do. And because of that, lots of people just stop there. And it's like, cool, you know, bicep curls are really good for developing your biceps. However, if you don't train how to use your arms in a coordinated way, you know, having big biceps doesn't mean you're going to throw better. Having big biceps doesn't mean that you're going to carry better. It just means that you've got the raw materials to improve your coordination and your performance. Great. You know, I don't know if you're old enough to remember Wendell Saylor, but Wendell Saylor put on more muscle as a rugby player. He used to run around at 105 kilos, I think. And then I think he got all the way up to 112 kilos in rugby. And he was just not as effective. So when he lost weight again a bit, much more effective. Like, just having more muscle doesn't mean that you're going to be better. You know, there's always a trade-off somewhere. So, you know, being able to recognize that those things are important is good, but it's not a qualification to coordinating it into your everyday life. So I hope I'm answering your question, Kelly.
Yeah. So then what's the indication to begin pelvic floor strengthening, and then how do you progress it into it being more relevant to daily life beyond just Kegels?
Well, I would say that the first thing you should do is check the coordination of what they have, right? Like, I think that would be more important to do. Coordinate your pelvic floor, find out if they're bearing down. For example, like, lots of people are classified as weak, but it's like it's like, say, a grip strength test. If your forearm muscles are already in an isometric contraction, and then you take your resting measure as whatever you are just then, and then you squeeze and you only get a small increase in the amount that you can squeeze, you might say that that person's weak, but they might be overactive. There's all sorts of nuance to it, of course.
So what is the, sorry.
No, I was just going to say that it's difficult to say why people should, like, if I said, okay, if you leak, you should do strengthening, that may not be true. You might be strong enough and you've got a coordination problem. So I'm hesitating to build a rule around why somebody should be given pelvic floor muscle strengthening exercises. And because I don't do internal examination, I don't get to decide, like, I don't get to see that. I have to rely on other people to give me that information. So, if you have weakness and, like, you're going to need coordination and strengthening training. And I rely on other people to tell me about if it's weak or not. And I trust that they know the difference between a coordination problem and a pure strength problem, and then a neurological problem. Like, they might have a neurological deficit. So, the coordination and the strengthening may or may not be helpful. They might be overactive. Like, there's a whole bunch that goes into it. It's why it's a specialty. How
the coordination issue is that a matter of the patterning of when the muscles are activating during certain movements? Is that what you're referring to?
Yeah, like, for example, you might have a good enough pelvic floor squeeze and lift, for example, to work against a cough or a sneeze. However, if that takes longer than a sneeze or a cough occurs, then you have a coordination problem. And that's why doing a preparatory gentle pelvic floor contraction might be useful. Now, lots of people think, because you do that, you create the kink, you guard against the pressure.
Yeah.
I think the way that it might work is that you change the length tension relationship to something that the brain has more experience with. And then when it activates, that timing, it's just in time so that you can guard against a cough or a sneeze. I think that's how it works, perhaps, or just one possible reason why it works, right?
Yeah.
And then from that, over time, does the body just get better at doing that without having to think about it as such? Is that what you're proposing?
I think that moving from conscious competence to unconscious competence is difficult to figure out, bottom line. So I like to use different steps to get there, and I like to test. I like to test for automaticity. I like to test to see if they're unconsciously competent already.
What automaticity?
Automaticity, yeah. Like, can they automatically do it already? And
I like that word.
Like, if they can already, if they're already unconsciously competent, they don't have to think about it and they can do it, then why would we drag them back into conscious competence with cues when they don't need to? Like, not everybody needs a pelvic floor cue. In fact, some of the best pelvic floor cues are the ones that are outside the pelvic floor. Cues are just words and actions that get the response that you're looking for. That's all it is. So, a common cue for transversus abdominis is to bring your ASISs in together. But your transversus doesn't work in that direction. Your transversus pulls them apart, really. But it works. So use it. Like, who cares?
Do you have just like a bag of kind of cues that you kind of use with different people and just trying to find what works best for them? Because I'm imagining some people just find it difficult, whereas other people might find like that's the one for me or makes sense for me.
Yeah, so like I said, I like to test what they can do first.
Yeah.
And then I like to get a sense. I'm old school, put my hands on, have a feel what people are doing in terms of coordination. So it looks like I'm feeling nothing specific, but I'm trying to sense a direction of coordination. Are they bearing down? Are they using a bearing down pressure to trigger a reflex pelvic floor contraction against it? Lots of people, including pelvic health physios, will do that. They'll use a transversus cue, or they'll use breathing out. They'll use something that increases pressure. There's another myth for you, that breathing out decreases intra-abdominal pressure. It's like, no, it doesn't. It increases it. But anyway, like there's a whole bunch of things that you can try. Do I have my favorite cues? Some, but I prefer to use just movement and actions to see what we can get, instead of specific muscle cueing. Specific muscle cueing is the worst. Like, it just makes people uncoordinated. And when you're dealing with people who are athletic, who are playing sports, getting people to think about a muscular contraction during a performance of some movement is not going to work out well. Like, okay, when you're going to run at this person and you're going to do a Euro step, I want you to plant your foot, making sure that you activate your plantar fascia to support the arch. And like, who says that? Nobody says that.
I always give the plantar fascia activation every step for that whole marathon you're running. You need to be contracting it, or your knees are going to blow out.
Every second step. Otherwise, that pronation or tibial torsion, your medial meniscus, and no.
Yeah. Well, I guess one of the questions we have was, do the females need to activate their pelvic floor before? I guess lifting, running, and jumping, though, you could say that they're different activities. You could certainly say they need to be able to, but they don't have to think about it consciously.
I think that you get the best performance if it activates, right?
Yeah.
Whether you need to consciously activate it is a different question.
Yeah.
It's a coordination thing, as well as a physiological, can you maintain the pressure that you need to execute the movement you want to do? Like, you need a certain amount of intra-abdominal pressure to stabilize the trunk so that you can drive force through it more efficiently. It's just physics. Physics is not dead. Biomechanics is not dead, but they don't explain everything either.
Yeah.
How would you, as lots of clinicians listening to this, and I actually know we have 54 based off our podcast information demographic, 55% of the people that listen to this are males and 45 females. How would you posture it to the males listening to this podcast around asking these kinds of questions? For, let's say they're not in that realm at all, but they're like, I think there's a couple of things here I just want to ask about, so I can send them off to someone that specializes in this. How would you kind of posture that or ask those questions? And I'm picturing, like, first few years, young male graduate wanting to send off but doesn't really know how to ask around this kind of topic.
Sure. There's a number of ways to do it. I think, first of all, you got to be true to yourself, right? So you got to find your own way instead of, but, people find scripts usually easier, or some sort of protocol or procedure. I get it. But be yourself, number one. And in that vein, don't be weird. Like, it's only weird if you make it weird. So if you start looking uncomfortable, you start going, this is girl stuff. Like, you're making it weird, dude. Stop. Right? Like, like women have seen male doctors.
Away, look with your eyes down.
There's no need to be like that, right? That's the first thing. Second thing, ask for permission. It's like, hey, I've got a series of questions. You don't have to answer them. I actually don't need to know the answers. If you answer yes to any of these, it might be helpful to find a pelvic floor physio to be able to help you with these things, because it may be relevant to your condition right now. And then say, is it okay if I ask the questions? And again, you don't need to answer them. If you feel uncomfortable, that's cool too. So you're asking for permission first. I think that's
I really
a great
like
step.
That's awesome.
Like, just ask for permission.
Really good.
The other way to do it is to standardize it. On your intake form, have a pelvic floor screening questionnaire for people with low back pain, hip pain, pelvic pain, pregnancy, postpartum, like whatever, and then just have on there, hey, we know that some of these conditions can also present with symptoms of low back pain or pain in the hips, pain in the pelvis. And so it might actually be relevant for you. If you don't feel comfortable talking to somebody, we do have other therapists who you can talk to. Or you can just talk to your doctor about who to see if you don't want to talk to us about it. Like, people are usually okay if they know that you're not trying to, no, you got to tell me, okay, what's your favorite sexual position? Because that pain that you have, do you know what I mean? Like,
yeah.
Like I said, don't be weird.
Yeah. I like that. I like the free framing, because we ask this question all the time. This question then asking females around regular menstrual cycles for like low energy availability. And I've lots of people I've never heard it explain like that. So I really like that. That's awesome.
Yeah, and okay, an example for me is I've got somebody in, say they're 14, 15 years old, female, with knee pain, Achilles pain, leg pain, high hamstring pain, and you want to know, have they stopped growing or not? And on average, women stop growing around 2 years after their first menstrual cycle. So I say to people, hey, you're of the age where I don't know when you had your first period, and you don't need to tell me, because I don't even know if you are having a period. However, this is why it's important to me. If you still have a growth plate and avulsion is a thing that could be part of your pain presentation, it may be worthwhile that we go check that out. Will it change how we do things? Maybe, because if you are avulsing that growth plate, maybe doing really heavy Nordics right now is not appropriate for you. Do you know what I mean? And so you just explain it. Usually they have a parent there. And also the thing, hey, there's a condition, we call it red S. And one of the things is, if you've had your period and then you've stopped having your period, this is something that is an indication that you may have other clusters of symptoms. So if you don't feel comfortable telling me, that's okay. But I would like you to tell somebody that you trust. And then you can even email me later if you decide, okay, I will tell you. And giving people options instead of, because the power dynamic is always there, no matter how nice you are. So, just recognizing it and giving them the option, hey, you don't have to tell me. It's not the end of the world if you don't tell me. I just want you to know that it's a thing, and you can go check it out, and you can go talk to somebody else about it, and just let me know and just tell me. And
that's awesome.
If they do consent, the other thing that I like to say a lot is, okay, thanks for letting me do that. So for example, if I'm working on their ribs, I've got somebody recently with throwing pain, left arm, and pain all through here.
You're pointing to the middle of your chest for the listeners.
Sorry, I'm pointing to the ribs. I'm pointing to the ribs, so the sternal attachments of all sorts of muscles. And it's like, okay, I would like to examine this area. This is what I'm going to be doing. This is the reasons why. Is that okay? They give me permission. And then I say, okay, now, if you change your mind, thank you, I'm going to do it. But if you change your mind at any time, it is okay to change your mind. And if you say, you know what, I don't feel comfortable with this anymore, I will stop straight away. And that's okay. So being able to say that, and just get proper consent, ongoing consent. And just because they consented last time doesn't mean they're consenting this time. So I ask actually every time. I don't ever assume that they've given consent this time. And, the patients are really funny. They're like, yes, you can. You can. It's like, I'm going to ask you every time. I don't care what you say. Because if I get called up, I know I can call on everybody to say, you know what, he does annoyingly ask me for permission every single time. It's like, this is his pattern. Even though I told him he doesn't have to, he still does. Yeah.
That's awesome. And then I guess like from all of that, like moving towards like various types of pelvic issues that we might be treating. What are some of the common presentations that you're sort of seeing where you are having to take that approach of being, extra thorough and maybe ask some confronting questions at times in regards to, continence and prolapse and how we're sort of managing that from a rehab perspective?
So the conditions would be incontinence and pelvic organ prolapse, antenatal, antenatally. So they might have musculoskeletal pain, they might have pelvic pain, they might have, they're still continuing their activities, and they want to maximize their ability to maintain participation, the postpartum return to sport, postpartum anything. They might have pain, diastasis, pelvic organ prolapse, post-surgery, like all of these types of conditions. I'm always asking for consent, and then also, looking for other things like with your red S type stuff, just listening and watching for feedback and asking about what their training is like and their energy levels and what their eating is like. And, this doesn't have to be while they're sitting face to face with me. This could be while we're working on whatever it is that we're working on. Are they getting recurrent injuries? Are they not recovering from training? Like, all those classic little, there needs to be a much more holistic approach. Yeah, I keep getting these tears, and you can I have an ultrasound, and it's like, I don't know. And then I don't think that we should be holistic because of a whole bunch of things. I think we should be holistic as default and get specific where needed. So starting with a holistic approach, I think do you know what I mean? Like, if I hear these things, I get to think more broadly about these other things. I think we should just be more broad right off the bat. And it's hard because when you're doing a courtside quick assessment, like, you're not being holistic. Hey, how's your eating and your hydration been? Like, we're not doing that, right? It's like, you heard a pop. Where did you hear? Where did you hear it? Where do you feel it? I'm looking at 2 knees right now instead of 1 knee on the one leg. Like, like you're just dialing straight in. However, if my work is not seeing people as their first point of contact, but actually because people are not getting better, which that's the sort of work that I love. I love working with other physios, and I'm totally open for people referring people to me and then sending them back. Like, I love that sort of stuff. Being able to be holistic first, I think, is the preference, and then dial in. And then I think good physio assessment is, I'm sitting there listening to the subjective. I'm thinking, this is the thoracolumbar junction, compression, irritation of the superior cluneal nerves, everything fits. Therefore, that is what I'm trying to prove it is not. I'll go check everything else because I think that's the problem. I think you've done an ACL. I'm going to check everything else because I don't want to focus in too early. I think it's important to stay broad. Otherwise, you miss things. And so, sorry, I'm bringing it back to continence again, but when you are sort of assessing someone, there's commonly sort of a few different categories of incontinence that people can be experiencing, and the treatments for them can be quite different. So when you're listening to their history and then you're trying to make decisions about what it is, what are some of those key positive findings, and what are you going to be thinking about in that assessment to sort of prove your hypothesis right or wrong? Yeah, so number one, I try to prove it wrong. I don't try to prove myself right. Like, a diagnosis really should be the one that's left standing despite trying to prove it wrong. Like, to me, that's good diagnostic thinking, right? So with incontinence, for example, you have urge incontinence, you have mixed incontinence, you have stress urinary incontinence. And that's just the urinary side of things. Stress urinary incontinence is the most common, urge incontinence and mixed. Actually, mixed is probably the most common. They're all there. The management strategies for it, number one, I don't do the internal type work. So I don't do the internal management strategies that might be suggested by my internal colleagues. So for me, asking myself, well, what are the common things that no matter what I do, I'm likely not to be harming them, right? First, do no harm. Coordination, right off the bat. And if we're honest with ourselves, what we really are doing in our assessment is establishing what they usually do so that they can do something different in the hopes of creating a change. That's the simplest that I can explain what we're doing. We do something different. So let's establish how they generate pressure to do their lift, their clean. I have a consult series and I just did an update for one yesterday. She had pain and she had heaviness feeling from pelvic organ prolapse, and she had stress urinary incontinence. And from the consult and some other stuff we did on the course, she was going great. She went from being only able to do 20 double unders in jumping rope to being able to do, she said, I think 56 or 57. So she nearly tripled her ability without symptoms. By changing her squat stance and her knee tracking to be physiological and not the women are tiny men, let's make sure their shoulders so make sure their feet are shoulder width apart, toes forward, knees tracking over toes. Like, people are built differently. So for her right leg had a tibial torsion with an externally rotated foot more, with tracking on the inside of the big toe, and on the left side, still similar, slightly turned out, but the knee tracked on the big toe, just on the medial edge of the big toe. So when she was, in inverted commas, given permission to do this, in inverted commas, bad squat technique of letting her knees start there, it felt easier and she had no symptoms. She was able to lift heavier. So again, it's coordination and finding the different that makes a difference, or finding the difference, as in different with an S, finding the difference that makes a difference. That's ultimately what we are trying to do. And then we do it with all sorts of stories that back it up. But really, just be open to the stories being wrong and just go with the results that you have.
I like that too, because I would say that majority of people listening to this podcast probably aren't qualified in doing internal examinations and some of those more advanced assessments for continence. So it's really good to hear your assessments and management strategies with working with what we've kind of got in front of us, because I think that gives us all more opportunity to be able to help the people in front of us, which is cool.
Do you have any advice for runners, like gait advice? We say increase your cadence, wider steps, that kind of thing. Is there any kind of techniques or I know it's not black or white, like everyone has to do this and that's it, but are there any some common ones or common themes that you see to people that I have this when I'm running? Is there anything you can tell me or think about that would help with that?
Yeah. Look, I think short of an individual assessment, changing cadence covers a multitude of sins. You change somebody's cadence, they change their step length. You change their cadence, they change their foot strike a lot of the time. You change their footwear, they change their strike. There's a whole bunch of things. And then we can, somebody just took off to go to the Gold Coast Marathon today, I think she left, or Thursday. And I told her she's a ex-dancer. So I told her not such a high proud chest that you would like, that you prefer to run in, but like allow a little bit of slouch to occur because she was getting high glute pain that was irritated. Like, I think it's an irritated superior clineal nerve, if we were going to put a name on it. And that was helpful for her to be able to do. She knew in and of herself that it wasn't a hamstring tear. She knew that it wasn't sciatica. She's had both of those before. She goes, it doesn't feel like that. And when we went and addressed the thoracolumbar junction, L1 to 3, changed the technique a little bit so that she was more relaxed with this, because she had nice rotation. She wasn't excessively rotating through her pelvis. She had pretty good technique. Like I said earlier, the first part of what we do is establish what their current preferences are. And the second thing we do is we give them something different to do. And that should be a collaborative effort. But sometimes our job is to point out what they can't see. And so, that was really helpful for her. And I guess I'm going to find out on Tuesday when she comes back from the marathon. Well, the half marathon she's running, but she went up to the Gold Coast. We're going to find out how that goes for her.
Yeah, Kelly's doing the half marathon on the weekend too.
Oh, nice.
Like, team together. If you look for someone over, I spoke to someone. Yeah, interesting.
Sounds good.
Yeah. Do you see many runners with like incontinence and things like that?
I see many people with things. I see many people with many different types of things, and to me, I don't know how much you know about how I work, but I don't have a good memory. So I only got diagnosed with ADHD in 2019, which just made a lot more sense, because when I was just working as a physio, it wasn't a problem because a new patient every half an hour, like people with ADHD cope with that. But trying to run an education business and sitting and reading and writing and developing a curriculum and teaching, teaching's not the problem. It's the admin side that sucks. So I've always had to work by principles and not protocols, because I don't remember the protocols. So whether I'm seeing somebody with incontinence or whether I'm seeing somebody with medial knee pain during running, to me, the process is the same. What are you doing? What makes it feel better? Here's how you can explore it and find the things yourself and come back and tell me next time. So you asked me, what are some of the common things? So cadence is an easy one, but it's not a panacea. It doesn't help everybody. It's just an easy one because, you got 5 minutes left. You've got to give them something, right? So cadence is an easy one. And the other one is silly running. So
I haven't heard of this one before.